Firstly, I would like to thank Dr. Vishweshwaran for inviting me for this wonderful conference on sleep medicine. And from what I gather from a lot of you in the audience, most of you all do a lot of adult sleep work. I'm basically a pediatric pulmonologist who does a lot of pediatric sleep work. So I'll be talking to you a lot about what are the basic clinical scenarios that I see in pediatric sleep. How do we go about doing pediatric sleep studies? Of course, the talk I'm going to limit to 20 minutes, primarily because we have a workstation on pediatric sleep after this. So if you'll have any doubts, want to learn a little more, please do join the workstation as well, so we'll be able to continue in the workstation too. Just a minute. Sure. Thank you. So basically today the topic I'll be talking about is pediatric polysomnography, basic to advanced. So let's basically talk about what are the types of PhDs that we do in children. How is it different than what we do in adults? So many of us do pediatric sleep. I'm a pediatric pulmonologist and I was trained in sleep medicine in National University, Singapore. I also run a particular course called the Diploma in Pediatric Sleep Medicine, and we also run a fellowship in pediatric sleep as well. Now, we need to understand that sleep issues in children are not uncommon. Nearly 25% of children aged between 1 to 5 years do present with sleep problems. Now, when we talk about pediatric sleep, let's not think it is only obstructive sleep apnea. Remember, 1 out of 4 children that we see in a pediatric OPD does have a sleep problem. And even what are the different spectrum of these that we need to see? Now, pediatric sleep issues that we see are again a little different from adults. In pediatrics, as pediatricians, we talk about each age, everything is different, right? So we spoke about the sleep stages in the previous talks, where the sleep stage in infancy is different from pediatric age group. We need to understand that this is different from adolescence as well. So as a pediatric sleep specialist, so when you start doing pediatric sleep, just doing a single criteria for diagnosing may not be enough. Just looking at it in a single point of view, as you saw in an adult, may not be enough. The age makes a very big difference. A child, depending on the age, may vary, depending on the development, may also vary. And the knowledge today in pediatric sleep is expanding. Of course, in adult sleep, we have people who are so reputed and people who have done a lot of work over many, many years. We were one of the only few who started pediatric sleep work after being trained itself. So yes, knowledge in pediatric sleep is expanding. So what is the kind of profile of patients that we see? This was my publication in the Karnataka Pediatric Journal, where we basically wanted to give an overview of what are the pediatric cases that we see in a pediatric sleep clinic. Now, when I have an exclusive pediatric sleep clinic, the most common pediatric patients that we see, around 36.5% come with infant sleep issues, around 24% come with suspected obstructive sleep apneas in an otherwise normal child, around 18% come with neuromuscular disorders, either Duchenne muscular dystrophy or spinal muscular atrophies. And other 15% are referred from genetic syndromes, predominantly Downs, Prader-Willi syndrome, mucopolysaccharidosis, Smith-Magenis syndrome, Cruzon syndrome, osteogenesis imperfecta. Around 4% come to your sleep clinic in the form of parasomnias, and probably 1 or 2 come with abnormal movements during sleep. So if you look at the spectrum, it is very different than what you are seeing in an adult sleep clinic. So when you do pediatric sleep, when you start telling people that you may be an adult physician who's doing pediatric sleep, when you start telling that you're going to do pediatric sleep, this is the kind of spectrum that you're going to see of patients. It's very different than what you're seeing in an adult sleep clinic. What are these infant sleep issues that you basically encounter? When I say infant sleep issues, a lot of parents come to us who are less than 2 years where the child is just not able to sleep. Right? This is very common. I'm sure many of you are parents, and many of you as parents itself would have faced a lot of sleep problems in your babies, right? When you become a parent, the first thing they tell you is forget about sleep, right? Which is not true. So babies can come with either problems with sleep regulation, self-soothing, abnormalities with sleep consolidation in the night, sleep onset associations. This is a child is just not able to sleep without breastfeeding or without being rocked, without a mother or father being carrying this child around. Remember, today, especially like since I work in Bangalore, the kind of parents that we are seeing are completely different than what we used to see even 10 years back. Today's parents are very well educated about sleep. I get a lot of parents themselves seeking out help, saying that my child is not sleeping well. So as a sleep specialist, I'm coming to you for consultation. The baby is waking up at least 6 to 7 times. And remember, today a lot of women are working mothers. So working mothers has to get back to work after 3 months or 6 months. And she's like, if this child is going to keep waking up every hour to breastfeed, I'm not able to sleep. How am I going to work tomorrow? I'm an IT professional. These are the kind of sleep cases that you'll start encountering, right? So a lot of them have a lot of night feelings, which mothers are not able to manage. But infant sleep studies are where we do not do sleep studies. So infant sleep issues most of them are behavioral. And what we do in our pediatric sleep clinics is we talk about sleep coaching, we talk about behavioral strategies, and how to overcome these sleep onset associations, and how to overcome these night feeding problems to help the mother. So you will see these children aged up to, let's say, 6 months to almost 3 years to 4 years, and many of these mothers and fathers are going to come to you saying, please help my child sleep better so that I can sleep better and go to work tomorrow. These are problems which will come now because, as I told you, parents are very, very aware of sleep issues now. No pediatricians refer them to me. It's the other way around. Most of the pediatricians would have told the mother that this is how life is with a child, please live with it. But the parents know right now, and they're going to start coming to you. So we need to start getting educated about infant sleep issues. Where PhD is not required, we talk about behavioral strategies here. So where exactly do we do PhDs in children? So the indications we classify in children as well as two, respiratory and non-respiratory indications. Most common, like in adults, we also talk about sleep apnea or sleep disorder breathing as the most common indication. Important cases which comes to us is pre-adenotonsillectomy. Now what happens, a patient has gone to one pediatrician and this pediatrician has said this child needs to undergo tonsillectomy or adenoidectomy. The moment you say adenoidectomy or tonsillectomy, a lot of these parents end up going to multiple doctors. And eventually they come to you and tell you, okay, this child is getting repeated coughs and colds, right? We talk about cough and cold going on and off, on and off. And one doctor suggested go for adenotonsillectomy. Should I do it or should I not do it? Please give me an answer. This is a very difficult question to answer. Why? Because everybody has a difference of opinion. Your ENT doctor says different, your physician says different. This is where a sleep specialist comes into play. We tell them that, listen, if you want to make sure that a child needs to undergo an adenotonsillectomy or not, for whatever reason, maybe recurrent upper respiratory tract infections, recurrent upper airway obstruction, doing a sleep study here can give us objective evidence to say, yes, can I go ahead with a surgery or not? And is this surgery going to be successful or not, is where a sleep study becomes mandatory. So world over, we do say, before doing an adenotonsillectomy for a pediatric child, for whatever reason you're doing it for, doing a sleep study is very important. Now, I come across the other way around. ENT doctors have just done adenotonsillectomies and the child has come back with obstructive symptoms. Here is a child who's come back with breathing abnormalities after that. So post-adenotonsillectomy, we also do sleep studies in especially children mild to moderate OSA who come back with residual symptoms. Now, who are these children who have residual symptoms? Those who have obesity, syndromes, or other abnormalities. Obesity is the biggest problem we're facing in pediatric age group now, especially after the COVID season. We almost in pediatrics call it the next epidemic of this decade because all the children are becoming obese because the activity has reduced, the food patterns have completely changed. So obesity with OSA is definitely rising. What we need to understand is the moment a child has obesity, it is an increased risk factor for residual OSA. Even if you're going to go ahead and do an adenotonsillectomy, these children may end up requiring CPAP or BiPAP. So which is why we counsel them, yes, your ENT doctor said go ahead with adenotonsillectomy, fine. But please do a sleep study before, please do a sleep study after, so that we clearly know whether there's residual OSA and we need to do something about it. We also can do sleep studies if you're going to look for other adjuvant responses like medication, oral appliances. We do it before we start NIV therapy for other reasons. I'll go through each of these indications in detail now. We do it for non-respiratory conditions. So in non-respiratory conditions, for the evaluation of PLMD in children, yes, we do it. Maybe not for diagnosis of RLS, because RLS may be predominantly a clinical diagnosis, but a lot of children come with movement disorders. Now, they come with abnormal movements. I'll try to show you some videos where they're just abnormal movements where they're moving around, hitting their heads, head banging. A lot of parents are very concerned about this. We may do pediatric sleep studies in them only if we feel clinically we're suspecting something else. PhD with MSLT, we know when we're suspecting narcolepsy. A few of these children may not present as narcolepsy per se, they come with hypersomnolence. Sleeping in school. Of course, sleeping in school is the most common complaint. The school is giving a letter, your child is sleeping in school continuously, please do something about it. A lot of them come to you with that report saying, doctor, do something about it. And we do PhD with an EEG, maybe even a 24-hour EEG monitoring to differentiate some parasomnia and abnormal movements from sleep-related epilepsy. And sometimes, suppose you feel some of these parasomnias look a little atypical. It's not something usual, parasomnia. That time we go ahead doing a sleep study. Yes, parasomnias are also common in your pediatric sleep clinic. I didn't project that because many times we don't do much. Most of the parasomnias, we see them and they're very obvious, clinically obvious. We don't do a PhD, we end up counseling them, especially sleep terrors, nightmares, coming with head banging. These are things which are commonly seen. We may not really do a PhD for most of them. Like the previous study spoke about level 4 levels of sleep studies are there, level 1, 2, 3, 4. And as previous speakers have reiterated, In pediatric age group, level 1 study is the only study that you must do. There is no other option. So you have to be very clear that if you're going to do a sleep study in a child, please ensure that it is a level 1 study. Now, obviously, what happens is the awareness of pediatric studies are lesser. Parents may not be affordable to do a level 1 study. So do I do something else in such a situation? So if parents say, okay, and also EEG leads, a lot of kids may be pulling out the EEG leads. Like it's a very obvious OSA. The parents don't want EEG. Many times the parents themselves are like, can you please not connect things on the head and those kind of situations. Such a case, we may do a level 3 study, but in my setup, we do, even if we are doing without EEG leads, we do it only in a hospital setup. So what you need to understand is the concept of home-based studies does not exist in the pediatric age group. So if it is a child, even if you're going to do a study with only your respiratory sensors, you have to do it in a hospital where I have a trained nurse who's observing this child, documenting basic things about this child, having a video recording of this child. You may not be connecting EEG leads, but you have a video recording, you have a nurse who's observing it and reconnecting the leads whenever the child removes them, and it is done in a hospital setup. So the cost factor does come down significantly, and the parents are also relatively happy to do this. So it's something like a level 3 study done in a hospital. Home study does not exist for pediatric. Oximetry studies, we literally don't do them. It's just as part of theoretical that we talk about level 4 studies as well. So before I do a PSG, we obviously need to evaluate a child. We need to take a detailed sleep history. We look for the height, weight, BP measurement, look for obesity. But what is different in pediatric and adult is you start looking at the child's face. You need to really observe the child's face to look for craniofacial malformations. Watch out for genetic syndromes, right? Many times a child may be coming into your OPD just walking in like this. She's just standing in your outpatient and she's just falling asleep, right? She's just standing there. So what are you observing in the face? Okay, fine, this child is falling asleep in your outpatient. But what are you seeing in the face of this child? Do you notice something different or unusual? Yeah, you do see that the jaw is relatively different, right? So it may be so subtle. This is a very obvious child, but in many of these children, it may be so subtle that the child may have things like retrognathia, the child may have a jaw abnormality, maxillary abnormalities, which may be mixed. Many of children who I see in sleep clinics, genetic syndromes are missed, even by pediatricians. There may be subtle genetic syndromes which may be missed, like Smith-Magenis syndrome, etc., which you need to look for. So in your when you see a pediatric child, if they're obviously having an obvious sleep problem, always suspect a genetic problem. Look for any genetic syndrome. Look for craniofacial malformations. ENT examination, yes. Look for the tonsillar size as well as the nasal patency. Examine the nose really well in a child. So the sleep study setup in a child is almost similar to that of an adult. We use all the sensors. We use 28 sensors for level 1 PSG, 15 sensors for the head, snow sensor, ECG, effort bells, leg, pulse oximeter. Important for us if you're doing a level 1 study with genetic syndromes is to ensure that you're doing a carbon dioxide monitoring. You cannot do a pediatric sleep study with a genetic syndrome or a neuromuscular disorder, which I will talk about, without having carbon dioxide monitoring because hypoventilation needs to be documented here, right? So we need to ensure that we either have a transcutaneous or an EtCO2. We obviously have a nasal flow and oronasal thermal sensor. Now all these leads are something that we will talk about in detail in the workstation, so I won't go into detail about them. But when you come to the workstation, we'll show you all these different leads in the pediatric age group, how to connect them and how to make it easier for a child. Now, what is the most important problem that when I talk about sleep studies to an adult pulmonology audience, the first thing they say is it is so difficult to do in a child, right? Are you sure that we can actually do a sleep study in a 2-year-old child? We do it. We really do it because it is something that is completely dependent on your technician and how you make PSG child friendly. So this is a very beautiful article which talks about how to make polysomnography a more child friendly approach. When we talk about pediatricians, we're not treating the child at all. We're actually treating the entire family, right? So even a sleep study is not only about the child, it is about the parents. Many times it's the parents' anxiety which makes the child not sleep. So what are the important tips that you do to make a PSG child friendly? First of all, parents are the most experts on their child. So anything you have a doubt about the child, presume the parent knows better than what you know about the child, right? So create it in an environment which causes less trauma. It should be a child-friendly environment. Most of us, you go to any pediatric ward, you see how colorful the wards are, how friendly the wards are, right? Most important thing I tell the technician is, from the needs of the staff, shift to the needs of the parent and the child. My technician calls me saying, sir, I'm not able to connect this lead, that lead, this lead, that lead. I'm like, fine, if you're not able to connect these so many leads, give me at least these 3-4 leads. It's not the need of your technician, it is the need of the child that you need to have. It's not a good guy, bad guy approach. Remember, the parent, child, technologist, all are on the same team. A child is not lying down. They call me technician, says child is just not lying down. It's fine. So what if the child doesn't lie down? I'm sure you can make the child sit and do the sleep study as well. So this is something that we also talk to them about. Psychological preparation. So before a child comes to a sleep study, we give them a lot of videos to watch. We tell the parents to watch these videos before they come to the sleep study. You have to prepare them almost for a week. I'm not joking. The parent comes to me and I do the whole counseling, send them the videos. They'll say, doctor, we'll watch them for a week. The father discusses, the grandmother discusses, the grandfather, everybody is involved in the child, right? So everybody watches these videos and then they come for the sleep study. How many of us can sleep in the sleep lab? Remember, it's not like an adult. Who all are going to sleep? Is the mother going to sleep, father going to sleep, both going to sleep? These are things that you need to discuss before you do a sleep study. So a child-friendly approach, positioning the child in a very comfortable position when you're connecting the leads plays a very crucial role. Remember, in a pediatric sleep study, it's not necessary that the child has to be lying down for you to get a perfect study, right? Even if the child is comfortable in a sitting position, go ahead and do it, right? Do as much as you can to get basic reading. So a lot of them ask me, how many hours is sufficient, right? This is a common question which people pose for us. There's very limited data on that, but approximately if you have at least 4 hours of sleep in a child, it is something that we can interpret. A sleep study setup is something which I will cover in detail there, but we go in a particular order in the pediatric age group so that we get it in a proper structured manner. We start the EEG placement in your 10-20 manner. After we place the electrode placement, then we go, this is your 10-20 placement which we will cover in the workstation as well. We then go ahead and place the electrodes on the head, and first we always finish the EEG connections. Then we wrap the head with a secured piece of gauze, and after we wrap the head properly, ensure that it is secure in a particular manner but not too tight because the child has to be comfortable. Remember, children are, it's very easy for a child to pull off the EEG. Child moves around a little, EEG comes off. So the EEG part of it needs to be very securely placed. So the moment you finish your EEG sensor, we place the snore sensor on the neck. Then we place the respiratory bells, effort bells. Then we place the leg sensors. Then we place the oximeter, nasal cannula, and thermistor are placed last. Right? So this is the order that we go in so that the pediatric sleep study comes out better. And as you can see, finally we tell them you're a ninja. We try to make them superheroes. A lot of kids want to be Iron Man, Spider-Man, whatever. We ensure that we tell them they're a superhero and you're ready for your sleep study. The normative values we look for after we start the sleep study, just like in adult, we look for sleep efficiency, latency, and the stages, which are slightly different than that of an adult, but we compare these normative values as we go ahead. But this is an important normative value which you need to know, right? Is the AHI. Whatever AHI you learn in adult is very different than the AHI we follow in the pediatric age group, right? So AHI, of course, over here, less than 1 is considered normal for us. Anything between 1 to 5 is considered mild OSA. 5 to 10 is moderate OSA, and anything more than 10 is considered severe obstructive sleep apnea. So this is very important in your pediatric age group. Many of our patients may come with auto-scored reports, which the machine has scored, right? There a big mistake happens because 5 to 10 is marked as normal in many of these children. But we need to understand that anything between 5 to 10 is actually moderate OSA in a child. Anything more than 10 is severe obstructive sleep apnea in a child, and we require active intervention at that point. Central sleep apnea index, less than 1 per hour is considered normal. So when I give a sleep report in a pediatric age group, I divide them into 2. I don't give a AHI directly. I give them into 2 groups. I say it's an obstructive apnea hypopnea index, and I give a score. I give a central apnea index, and then I give a score. So we divide them into 2, OHI and CAI, primarily because we deal with a lot of children with genetic syndromes. Now, in these conditions with genetic syndromes, central apnea index plays an important role. Whether I'm going to choose a CPAP or a BiPAP to manage this, central apnea index plays a role. So when you're doing a pediatric sleep study, ensure that this one difference is followed. You give a OHI, you give a CAI, and ensure that both are followed, and the values, as you can see, for OHI are relatively different. So in our diagnostic studies, which we did over a period of 1 year, we saw around 82 studies for 1 year. We saw 8 of them were normal. Obstructive sleep apnea was there in almost 87% of them. Mild was around 15%, moderate 42%, and severe 29%. So the maximum category that you're going to get in pediatric age group will be mild to moderate obstructive sleep apnea. And that is why you'll be wondering, how am I going to treat these children? RLS and inadequate studies are very less. Now, what you need to see in this slide, what I want you to see is an inadequate study. Out of the 86 studies, we saw only 2 came as inadequate studies, which is only 2% of your total sleep studies over 1 year. So we need to get the confidence that although pediatric studies may be technically challenging, they're not as difficult to perform as we all think them to be. So the one important studies that we do is in Prader-Willi syndrome. So Prader-Willi syndrome is a child who comes with a genetic syndrome with obesity. They have some mild amount of developmental delay and hypotonia, right? Prader-Willi is not that uncommon. So I specialize specifically in doing sleep studies in Prader-Willi syndrome. Here, sleep studies are mandatory to do, almost. So why is it mandatory to do is one of the treatments that we use for children with Prader-Willi syndrome is called growth hormone. And this is increasingly used. So who do you need to talk to about this? The moment you start doing your sleep work, talk to the endocrinologist. A lot of endocrinologists see Prader-Willi syndrome because they go to them with obesity, hypotonia, and other abnormalities. So literally all the pediatric endocrinologists in Bangalore are very well versed with Prader-Willi syndrome now and to refer them for a sleep study because they all start growth hormone. So why should you do a sleep study in a child with Prader-Willi syndrome? One is they have obstructive sleep apnea, but what has been shown is that if you give this growth hormone therapy without doing a sleep study or treating the OSA, there have been shown cases of reported deaths as well, and the OSA gets worse in a child with Prader-Willi syndrome if you give growth hormone without treating OSA. So now everyone has become very clear that, listen, if I'm going to start growth hormone in a child with Prader-Willi syndrome, I am going to get a sleep study done. So tomorrow when your endocrinologists become aware, they will start referring these cases to you saying that before starting growth hormone, can you please do the sleep study? So I usually do a sleep study. If the child is having OSA symptoms, I then start the child on CPAP or BiPAP, and after that give them a break of around 2 to 3 months, document that OSA is not there on the CPAP, and then give a clearance for growth hormone. So you will get a letter from an endocrinologist saying, kindly give clearance for growth hormone therapy by doing a sleep study. So yes, this is one of the cases where we do complex studies as well. So one of my papers that you can read in the Indian Journal of Sleep Medicine we published on a comparative study on children with PhD findings in children with Prader-Willi and non-syndromic children. So what we notice is in these children with genetic syndromes, when you take history, most of the parents will say there are no sleep issues. So history, doing questionnaires, all these really don't work in the pediatric age group. That is the reason why, though you have things like Epworth Sleepiness Score, etc., in adults where you follow them commonly in a sleep clinic, none of these scoring systems work in pediatrics because they are time and again shown that the parental perception of sleep issues is very, very less compared to what is actually shown on a PSG. So the question is very clear. Irrespective of the history, a child with a genetic cause of obesity, what we call as syndromic obesity, for example, Prader-Willi syndrome, you have to do a sleep study, irrespective of the child having any sleep symptoms or not. We have other conditions which are called like this, called Treacher-Collins syndrome. Here, what does the child have? Again, the child I showed you was actually not a Treacher-Collins, but you see other cases of Treacher-Collins where they have jaw abnormalities. So these are children which again get referred to you from your maxillofacial surgeon. So I'm talking about the different groups who refer to me, right? So we have maxillofacial surgeons. These are the cases which go first to him. Cleft lip, cleft palate surgeries. They go first to them, right? And they are also again very aware. So you need to again tell them, saying that, listen, I'm doing pediatric sleep studies. So your maxillofacial surgeons will pick up these cases and say, listen, I'm going to do surgery for these cases. Before I do a surgery, I need a sleep study done. So in these children, again, you look at the degree of OSA, many times peri-operative CPAP or BiPAP. So I say, listen, the OSA is quite severe, its AHI is around 10. So before you go doing your jaw surgery, before you go doing your cleft lip, cleft palate surgery, let us start CPAP. So I start CPAP, stabilize this child, and then they take them up for surgery as well. Mucopolysaccharidosis is very, very common as well. We have 6 types of MPS, out of which MPS 4 is the most common in our country, and most of these children have short stature, they have craniofacial abnormalities. All of them present with severe obstructive sleep apneas, which respond only to NIV therapy. So most of these children with MPS, we start them off on NIV, and then they do very well with the obstructive sleep apnea. So these come to your genetic cases, and what has happened is we're growing so advanced in pediatric therapies. So there's something called as enzyme replacement therapy. So though these are genetic syndromes, many of these children are given enzyme replacement therapy. So before you give enzyme replacement therapy, they will refer to you saying, please do a sleep study before giving ERT. We call it ERT or enzyme replacement therapy. Bone marrow transplantation. A lot of children with MPS 4 today undergo bone marrow transplantation. And the bone marrow transplantation teams are very, getting highly advanced across our country. So the BMT teams will refer to me usually saying that we are going to go ahead and do a BMT for this MPS child. I don't want this bone marrow transplant to fail. Remember, the BMT costs around 15 lakhs to 20 lakhs, right? I'm not going to do a BMT if this child's oxygen levels in the night are actually low. If the child has OSA and is having hypoxemia, I don't want to do a BMT. So what do? We do a sleep study first. We then stabilize them starting NIV. I document that the sleep study has overcome the OSA, and then they go ahead with bone marrow transplantation for MPS. Rohat syndrome. Recently, I had a child who underwent an ENT surgery, was a child with Rohat syndrome. This child had severe OSA on clinical symptoms. Child was snoring a lot, has gone to the ENT. Clearly, they've told the child has developed obesity over the past 6 months. The child was completely fine. Only over the past 6 months, the child has increasingly put on weight. Still, the ENT said, let's go ahead with an adenotonsillectomy without a sleep study, right? So without a sleep study, adenotonsillectomy was done. Child collapsed on the table, had to be ventilated for almost 3 days. And after 3 days, they extubated the child, not knowing what exactly happened. It was only an adenotonsillectomy. Why did this child not wake up after an adenotonsillectomy for 3 days, right? That is when they referred to us after that, and we realized that this is a child with Rohat syndrome. Rohat syndrome is under-recognized primarily because we don't know about them. But they do come to us in our sleep clinics, right? So ROHAT stands for rapid onset obesity, hypothalamic dysfunction, hypoventilation, and autonomic disturbances. So these are the children who have significant hypoventilation on their sleep study. You start seeing their CO2 build. So what happened with this child was the child was actually hypoventilating. Post-surgery, this child was hypoxic with hypercapnia and was not able to extubate. So after ventilating the child for 3 days, they were able to extubate. So you will see Rohat syndrome in your sleep clinic. So any child with obesity, do a CO2 monitoring. If you're not able to do TCO2 or ETCO2, at least do an ABG the next day morning to make sure that this hypoventilation is not very significant in these children. Down syndrome, the most common syndrome that we see. Basic criteria here, American Academy of Pediatrics says every child with Down syndrome has to undergo a sleep study by the age of 4 years, right? Which means that every child you see with Downs has to have a sleep study. No doubt about it, because respiratory failure and OSA is one of the commonest causes of death in children with Down syndrome. Achondroplasia is the case which comes to me commonly. Very different, because here we see more of central apneas. So these are children which come very early. So they're diagnosed usually by 1 year, 2 years. They know that this child has craniofacial abnormalities. This child is achondroplasia. Refer to a sleep study to look for central apneas. Why? Because the foramen magnum in these children get compressed. Because the foramen magnum gets compressed, these children have a lot of central apneas. We directly start these children on BiPAP very early, and their survival is much, much higher. The last common studies we do are titration studies. So once we start NIV in all these genetic syndrome cases, we do something called as a titration study separate. Now, how is it different from your adult is what I'm going to talk about. Here, remember, we don't talk about auto titration. Even if you go world over, a lot of us have moved away from auto titration studies in the pediatric age group. We manually titrate. So how do we manually titrate? We have a sleep technician sitting there and doing a manual scoring and completely increasing the pressure by 1 centimeter every time they notice an obstructive sleep apnea, mainly till it is completely eliminated. So the titration for a pediatric sleep study has to be done manually. So that is an important thing, that take-home message that you have to take home, which is different from an adult. Do we use auto CPAP or BiPAP? Literally, I've never used auto CPAP or BiPAP, even in my pediatric age group. Very difficult for all our patients. So we manually set the pressures, and even in the machine we say don't use auto CPAP, auto BiPAP, please set the pressures manually for these children to take NIV home. So there's no role for auto titration in pediatrics. I usually recommend a titration study after 6 to 12 weeks of initiation. So we initiate a sleep study. It's not difficult to initiate NIV. As you can see, the number of data I've been presenting, NIV is very, very commonly used in pediatric age group as well. So don't hesitate about thinking of, really, can I do NIV in a child? Yes, a lot of our patients are doing NIV. It just depends on how you give the positive encouragement, distract the child, and role modeling on the parent as well. Let's talk about parasomnias. Can reduce the volume? Yeah. Yeah. So if you observe this child, this is a common video the mother sends. You're not able to console this child at all. So this goes on for at least 15 to 20 minutes. It just keeps going on and on, right? So the mother's obviously troubled because this is going on literally every 2 hours. The child does this for around 15 to 20 minutes. And after that, the mother's like, listen, please just do a sleep study and tell me what is wrong. So would you do a sleep study in this child? How many of you would do a sleep study in this child? Okay, what do you think is the diagnosis in this child? I had to sleep related because it's happening in sleep, but it's a parasomnia. Okay. So I would label this as a confusional arousal. So when we talk about in parasomnias in children, we label this as what we call as a confusional arousal. The reason I put this up is we don't do a sleep study in these children. You really don't need to do. So you will come across a lot of parasomnias where we really don't need to do a sleep study, which is where your expertise on pediatric sleep comes into play. And that's why I'm saying that not all sleep issues in children require a PhD. It requires more of your knowledge on pediatric sleep and how you counsel these parents. So of course we counsel the parent on confusional arousal, and they were better after that. So we will talk about more about pediatric sleep issues in the workstation that we're going to talk about. We have. I give you a brief overview so that you get the differences between adult and pediatric sleep. Don't hesitate to deal with pediatric sleep issues even as an adult physician. Be confident that if you're running a sleep lab, please deal with them, because if a child sleep well, the parents sleep well, happy parent, happy family, and as a doctor you can sleep well too. So if you want to learn even more detail about pediatric sleep, we do run a course in Bangalore which is called the Diploma in Pediatric Sleep Medicine, which is a 6-month online course. And I know a lot of you who are doing the courses here, many of you who have finished the course with me are here. If any of you are interested in that, we are collaborating with the University of Colorado for this course. Please get in touch with me if you really want to know more about pediatric sleep medicine. Thank you.